Welcome to session 6. We're looking at Oesophageal Atresia and Tracheoesophageal Fistula and Pyloric Stenosis. This session deals with some congenital anomalies of the GIT. Notably among these, we will look at Oesophageal Atresia, Tracheoesophageal Fistula, and Pyloric Stenosis in the child. Students will be taken through the etiology, the clinical manifestations, management of children with these disorders. Goals and objectives. By the end of this session, students will be able to define Oesophageal Atresia, Tracheoesophageal Fistula, and Pyloric Stenosis, identify their etiology, describe the clinical manifestations of these, and manage them appropriately. So these three major topics will be discussed. And once again, this is for our further reading. So Oesophageal Atresia, by definition, is a congenital surgical condition that affects the alimentary tract. The esophagus fails to develop as a continuous passage. Instead, it ends as two separate blind pouches. In a typical oesophageal atresia, both oesophageal segments are blind pouches and has no connections to the airway. Sometimes, however, there may be a fistula involved that may connect to the airway. Failure at the embryonic development is what causes this. The cause actually is unknown, but in most cases, it's known also to run in families, so it has some inheritable genetic factors and also associated with some syndromes, the teratogenic influences in the environment as well. And for our pathophysiology, we say that when this happens, failure of the tube to unite or flow as a continuous, it happens before the child is born, and therefore is considered to be caused by teratogenic effects such as drugs or rubella infection or any other viral infections. And most of these babies are born to mothers who have suffered some excessive amniotic fluid we call polyhydramnios, and so it is also highly associated with that. Oesophageal atresia is the first topic we're looking at. So there are various types depending on the level. So the type 1, we have the proximal and the distal segments of oesophagus are blind. There is no connection to trachea. So it's purely GIT. 1, the upper and the lower segments are not connected. 2, the proximal segments of oesophagus opens into trachea by fistula. Distal segment is blind. This is rare. Type 3, proximal segments of oesophagus has blind end. The distal segments of the esophagus connects to the trachea by fistula. And type 4, we have oesophageal atresia with fistula between both. And the 5th type, we have both proximal and distal segments of oesophagus opening by fistula, no oesophageal atresia, and usually diagnosed at birth. So here we are with various forms that we talked about, type 1, type 2, and on it goes. See the connection. Here you see both the distal and the proximal part are connected. So all that we have said is what you are seeing here. I'm sorry you cannot see as I'm using the arrow to show you. But as I have described earlier, you can see in the picture that this is what is showing you. Clinical manifestations. There is excessive drooling because the passage is blocked. So there is salivation and it's affected in children affected. profuse bubbling on oral mucus appears. And then there is dysphagia, and there is tachypnea, and this dyspnea is connected to the airway, and then intermittent episodes of choking and cyanosis. Regurgitation after initial and subsequent feeding, and all that I've listed here are evident. Diagnostic tests are those that have including physical examination and chest x-ray, all will help us to diagnose the problem. So in our management, immediate, they prop the child up to help, and gastrostomy, which is a temporal opening on the stomach to aid feeding, because the GIT is, the esophagus is blocked, and then oesophagostomy is a corrective surgery that is done. So here is a child. You see here, once again, the esophagus is joined, and then the ends of the esophagus are sutured together. This can be done. The surgery is performed by slits on the chest, as you can see, and not that we cut the throat of the child. Supportive therapy. You need nutritional requirement and IV fluids, antibiotics, respiratory support. All these are required, and also prevent infection, so you promote the surgery. Prompt primary repair. Division of the fistula is followed by esophageal anastomosis of proximal and distal segments. In the short term, subsequent primary repair is used to stabilize the infant and prevent deterioration when the patient's condition is contraindicated. So we talked about the gastrostomy, which is done sometimes to pay. And then also the staging, the infant's fistula division and gastrostomy with later secondary esophageal anastomosis may be used. And so you see the nature of the surgery described here for your understanding. And then preoperative care. You maintain the indwelling tube, ensure that it is patent by irrigation with 1 ml normal saline solution frequently, and then we change the catheter also frequently as needed, at least once every 12 to 24 hours by the physician. And then we alternate the nostrils and take care to prevent that the necrosis of nostrils from pressure by the catheter. So it's very, very important that we pay attention. And then place the infant in the incubator or under the radiant heater to provide warmth, administer oxygen, and also alert the doctor or surgeon of any signs of respiratory distress, as we have seen. And I think we have discussed this extensively in our high-risk unit, so you appreciate this better. Also monitor parenteral fluids, and then also observe the infant carefully for any change in the condition and report immediately, and administer antibiotics and other prescribed medications, and carefully observe and record everything in terms of change in symptoms. Post-operative nursing intervention. Once again, after surgery, we have to maintain a patent airway and ensure that we administer chest physiotherapy by changing and also giving the necessary, massage and vibrating, not too vigorous, and aware of the type of chest drainage present. Also, we ensure that it also drains carefully, and then ensure that nothing blocks this, and it's also not kinked. And there is also the need for us to assist in maintaining adequate nutrition. We have said that this is very important, and feeding via gastrostomy should be done under gravity and not pushed. Care should also be taken to allow the food to go down slowly. That's what I was saying. And oral feeding may begin 10 to 14 days post-operatively. And we have to provide the infant and the family with the necessary support. Post-operatively, complications that may occur. There may be the likelihood of failure of the anastomosis, and so there will be leakage and recurrent fistulas, achalasia, feeding problems with older children. So all these and more, but this is what we have been able to elicit for you. So now we go to our second topic, that is tracheoesophageal fistula, that connotes communication between the esophagus and the trachea. By definition, we say that this is a condition in which the esophagus terminates before it reaches the stomach, or a fistula is present that forms an unnatural connection with the trachea. We know that the esophagus is a GIT, and then the trachea is the windpipe. So when there is an unnatural connection, then whatever is going down the trachea esophagus will enter the trachea, and this condition causes oral intake to enter the lungs, and large amounts of air enter the stomach, and choking, coughing, and all abdominal distension may occur. So these once again are the examples we have here, showing you the degree and the nature of the esophageal fistula, tracheoesophageal fistula, TEF, as is called esophageal atresia. So once again, the symptoms are here and they are very clear: frothy, saliva and abdominal distension and all that. Post-operative nursing intervention will perform endotracheal intubation and mechanical ventilation if respiratory distress occur, and also place the infant in an incubator for warmth, and also humidification of air to help expectorate where necessary, and then also maintain nil per os until surgery is done, administer IV fluids as prescribed, and also suction any secretions. So there is a need for further referral into the appropriate facility that is well equipped with staff and take care of the interventions. So now our third topic is pyloric stenosis. It is also a common condition which occurs when children or newborn, occurs when the circumferential muscle of the pyloric stenosis becomes thickened, and here it results in elongation and narrowing of the pyloric canal. This produces an outlet obstruction and compensatory dilation and hypertrophy because it's thickened, and also there is some hyperperistalsis of the stomach. This condition usually develops in the first 2 to 5 weeks of life, causing projectile bilious vomiting, dehydration, metabolic alkalosis, and growth failure. So the incidence, we're saying that there is 1 in 3 per 1,000 births, and it is more common in male children than in females, and it's more common in full-term infants than preterm infants. So the cause, as you can see, is unknown. However, genetic predisposition is higher in first-degree relatives. So the pathophysiology, we see that the circular muscles of the pylorus is grossly enlarged as a result of both hypertrophy and hyperplasia. And this produces severe narrowing of the pyloric canal between the stomach and the duodenum. And as a result, the lumen becomes obstructed, and the inflammation and edematous occur later. And this further worsens the closure and also completes the obstruction. The muscles become more thickened and almost assume a consistency of a cartilage. And the distal portion ends abruptly and easily palpated abdominally, whilst the proximal end emerges into the gastric antrum. So this is what you see here, where you see the thickening and then where it affects by the thickening of the muscles as described earlier. So the clinical manifestations you have here is the projectile vomiting, and it goes very far and usually occurs shortly after feeding, the vomiting, and that is the characteristic. The projectile vomiting is characteristic and affects each feeding. And non-bilious vomitors that may be blood tinged may occur in chronic hunger, and the infant becomes easily hungry, and especially after vomiting episodes. So there is failure to thrive, there is some degree of dehydration, and then visible gastric peristalsis because of the thickening that occurs in the muscles of the stomach and even at the epigastrum. So diagnosis, we have physical examination, ultrasound, GI, radiography are all done for diagnosis. And the management, we all know this is by surgical intervention, what we call pyloromyotomy, is a mouthful, and pyloromyotomy is a standard therapy for this disorder. And before the surgery, there is a need to rehydrate and make sure any electrolyte imbalance and metabolic alkalosis are all corrected. NG tube is inserted, we decompress the stomach, and however, these fluid and electrolyte imbalances are not evident, surgery is performed without delay. The procedures performed include the threaded Bramstead surgery, what we call pyloromyotomy, is the name of the surgery done, and this is done through a longitudinal incision or through circular muscle fibers of the pylorus down and not including the submucosa. So basically, this surgery is performed. Specific pre-operative care. We need to reassure the family that something can be done about it, and then we proceed to prepare the child for surgery. No per hours, we administer IV fluids and hydrate the child and correct all imbalances, and then also assess vital signs and record intermittently, and assess the skin mucosa and ensure that the child is not dehydrated, and assess the child weight daily, and also pass an NG tube to decompress the stomach, and also assess and record any type of an amount of drainage that is drained, and also prepare the child and the parents about the care. So specific post-operative care. We're saying that because of post-operative vomiting is common during the first 24 to 48 hours, we administer IV fluids, and then we pass NG tube to drain the stomach of its content to prevent failure of the surgery or vomiting, which will worsen, be very painful. And we assess the vital signs and maintain straight input and output chart, administer analgesia to reduce pain, and also inspect the incision for any signs of infection, and also feed. They are usually instituted soon after surgery. Usually, we said within 6 hours, the surgery, the child is fed. Initial postoperative feeding include electrolyte solutions such as Pedialytes or sterile water. So it is clear fluid retained, formula then is started just to test for tolerance, and then we also observe the feedings and record them appropriately. We also need to care postoperatively and observe for any drainage and signs of inflammation at the incision. We've said this earlier, and encourage the parents to remain with the child so that will enhance bonding and also help the child who has full emotional support by presence of people who are familiar, like the caregivers. And then also, because vomiting is also projectile in nature, it is frightening to parents, and they often believe that the surgery might have failed, so that can be stressful. So there is a need to prepare their minds for this one. So for the end of our session, we're saying you need to do further reading to look at some other congestive GIT conditions like herniations and other congenital diaphragmatic and abdominal hernias. So the reference are here for you, and this brings us to the end of our lecture. Thank you.